Hi, I'm David Irwin from the University of Pennsylvania.
And hi, my name is Dave Coughlin. I am an assistant professor at the University of California, San Diego. And today we are going to be discussing a manuscript that was published in May of this year in the Neurology Journal that is entitled Clinical Trajectories at the End of Life in Dementia Patients with Alzheimer's Disease and Lewy Body Neuropathological Changes. Very quick summary, this is a study of 62 autopsy-confirmed patients who had either pure Alzheimer's disease, 34 of them, pure DLB, 11 of them, or mixed AD and DLB pathology, 17 of them. And it details their cognitive and functional trajectories over the last several years of their life after a clinical diagnosis of dementia was established. I think that this is a really nice paper and with some pretty interesting main take-home points, and namely the big ones where I thought that the patients who had DLB had a rate of cognitive and functional decline that was approximately double those of the pure Alzheimer's disease group, and that the mixed pathology group, the AD and DLB group, had a functional decline that was also approximately twice that of the pure Alzheimer's group. I think this article is remarkable for a couple of reasons. One, it uses extremely rare data in that there is longitudinal clinical assessments in these patients that is paired with neuropathological confirmation. And it's one of the very few papers that has functional assessments like these activities of daily living and dependency scales that are paired with this type of neuropathological assessment. So definitely worth taking a look at. For background context, Alzheimer's disease and DLB, most common and second most common neurodegenerative dementias, and clinical AD is marked by progressive episodic memory impairment that goes on to involve other domains of cognition, and DLB has core features of subcortical dysexecutive dementias with some Parkinsonism, visual hallucinations, cognitive fluctuations, and REM sleep behavior disorder. However, clinical diagnosis for these syndromes is often imperfect, and autopsy validation remains the gold standard for definitive diagnosis of all of these diseases. Furthermore, it becomes not uncommon to observe mixed pathologies at autopsy. It's probably about 70% of DLB patients will harbor intermediate or high levels of AD neuropathology when they come to autopsy. And in those patients, it probably influences their phenotypic expression. They're less likely, we think, to manifest issues like visual hallucinations and other core DLB features, but they also have a higher burden of episodic memory deficits, it looks like, as well. And truthfully, this has actually become part of the neuropathological assessment of DLB, which looks at not only the distribution of Lewy bodies and Lewy neurites, but has also integrated the burden of AD co-pathology as well. And in Alzheimer's disease cases, probably about half of them will harbor some degree of Lewy body pathology. And for many of these are concentrated mostly in the amygdala, but there's a decent number of them who will also have limbic or neocortical stage disease as well, anyway.
That's a great point, David. I think it's great to discuss. I really like this article for the reasons that you mentioned. And I think your perspective as a movement disorder specialist and mine as a cognitive specialist, and having both, we've had the privilege of getting training in experimental neuropathology to see the spectrum of these pathologies that I was always surprised learning that DLB had such a high rate of AD co-pathology under the microscope. And really, similarly, as you pointed out, Lewy body pathology is a common mixed pathology of clinical AD with AD pathology, as addition to other co-pathologies that can influence cognition. So this was really a nice take-home point for this paper, is that by looking at the biological groupings, we could see these robust clinical and functional outcomes. And I think that, what we both experience in clinic is that when we see patients who have mixed cognitive and motor features, and it's well described in the literature, the functional deficits are additive. So patients who have problems with memory and Parkinsonism, their ability to take care of themselves independently is much more impacted, and it's so much harder to implement supportive care. And I think that, like you mentioned, the fact that they use functional assessments in this study was really a strength.
Yeah, and it really looks like the literature on rates of progression in general in DLB and AD is pretty mixed. I mean, there's certainly several papers that would suggest that DLB has a faster rate of clinical progression across a variety of different measures. But yeah, having that extra aspect of Parkinsonism and the neuropsychiatric symptoms that go along with DLB suddenly adds like some extra burden there anyway. A lot of those studies have relied on those clinical diagnoses and often don't have that autopsy validation. So there's probably some expected degree of clinical inaccuracy that's built into the studies. And of course, a lot of them aren't really able to assess for the burdens of or impact of co-pathology on some of these things. So this is a very valuable paper that was able to look at those things as well. I mean, in our work anyway, and those of others too, you know, we've shown and seen that having concurrent AD pathology, either if you have Parkinson's disease or dementia with Lewy bodies, it tends to be related to the sort of faster rate of clinical progression as far as their cognitive features goes anyway, and seems to decrease their overall degree of survival as well anyway. So yeah, it's been nice to actually see this like functional impairment, which seems very clinically relevant to go along with some of the things we're a little bit more used to collecting, both in the clinic, but also for some of these like clinical trial outcomes too anyway. So I think this paper provides some more clarity on this clinical course using these biologically driven groups, like you mentioned too anyway.
Yeah, it's very timely too with the advent of FDA approved AD biomarkers. You do a lot of great work in this area, and many groups have, you know, there's still some caveats into how to interpret AD biomarkers in the context of synucleinopathies or Lewy body disorders, but AD pathology with PET imaging and newly FDA approved cerebral spinal fluid assay, well, it's still largely in the research realm, can help us visualize or detect these pathologies in living patients. So having this autopsy longitudinal data is so important to guide future studies, and clinical trials often do look for functional outcomes as a endpoint for trials. So this was, you know, another good strength of the study.
Yeah, and you talk about, you know, AD biomarkers and everything, and as you know, there's been a flurry of alpha-synuclein related biomarker papers over the last couple of years using these like synuclein aggregation amplification assays, you know, the alpha-synuclein RT-QuIC platforms and the PMCA, and you know, a lot of very interesting stuff coming out now about their ability to detect synuclein seeds from a variety of biologic tissues. I mean, it does seem like we're starting to move towards a place where we'll actually be able to characterize our patients, not just in terms of their phenotypic presentation, their cognition, their movement disorders, but also probably be able to do a pretty good job of at least assessing the presence and severity of AD co-pathology, and at least the presence anyway of synuclein pathology in certain contexts too. So while a lot of these studies are, you know, autopsy validated, and we love autopsy validated stuff with our, you know, work in that realm anyway, it's nice that we're going to be able to do a better job with this in living patients probably quite shortly too. Mm-hmm. Am I okay to start jumping into the paper in that case?
Yeah, I think that was a great review of the background and the strengths of the paper, and it'll be fun to dig into the methods and some of the data.
Yeah, sure. So the subjects that they used for this study were from the Predictors 2 study, and this is a clinic-based cohort where they had recruitment sites at Columbia University, which is in North Manhattan, Johns Hopkins in Baltimore, and Mass General Hospital in Boston. So participants had a variety of assessments that were collected every 6 months, and that included medical, neuropsychological, and these functional and dependency measures. They started with 211 patients who were diagnosed with clinically probable AD, and 28 of which who had clinically probable DLB. 78 of those folks participated in brain donations. Right off the bat, that's a very high rate of participation in brain donation, so that's already laudable. So of those 78, they had to exclude patients, 8 of them who did not have any alpha-synuclein immunohistochemistry, 7 who, quote, did not have features of DLB or AD on neuropathology, and 1 of which who didn't have any longitudinal data. So that left them with 62 cases to work with for the paper. And again, 34 of them were Alzheimer's, sort of pure AD pathology, 11 had DLB, and 17 were mixed DLB and AD neuropathologically. Clinical diagnosis of AD was determined by applying the National Institute of Neurological and Communicative Disorder, Stroke, Alzheimer's Disease and Related Disorder Association criteria. And the DLB criteria was applied using the second consortium from the 1996 McKeith et al. Criteria. And the clinical measures that they collected were the Folstein Mini Mental Status Exam, as well as the Activities of Daily Living subscore on the Blessed Dementia rating scale, which is a scale from 0 to 16, with 16 being worse, functional impairment there. And then they also collected the Dependence Scale, which is a 13-item questionnaire that's given to the reliable informant or caretaker of the patient. And that's a scale from 0 to 15, with higher scores indicating worse dependency as well.
These scores capture very relevant clinical information about a patient's functional status, like their ability to feed independently or bathe independently. So very clinically relevant.
Yeah. In terms of the neuropathology, so a neuropathologic diagnosis of Alzheimer's disease was done if the folks had a CIRAD score of moderate or severe neuritic plaque pathology, and those who had a Braak-Tau stage of 4 out of 6 or greater. And Lewy body disease was determined if they either had limbic stage or neocortical stage alpha-synuclein pathology by immunohistochemistry.
So for a neurology audience, it's helpful to contextualize how the neuropathologists formulate their diagnoses. And as you mentioned, there are these different stages or scores for the distribution and severity of plaques, tangles, and alpha-synuclein. That helps formulate the diagnosis of what the likely probability that a postmortem finding and influence the clinical features of dementia. So with higher Braak staging or the stages of sequential tau, more likely to have Alzheimer's disease in addition to the plaques. And Lewy body, we think in most patients, propagates up caudal to rostral spread from the brainstem into limbic and neocortical regions. So that distribution and severity by the neuropathologist helps formulate these groupings that we see that are, like you mentioned, AD, mixed AD, and pure Lewy body disease. It was kind of interesting, the breakdown too. I think you're probably going to plan to talk about this in the results jumping ahead, but the clinical diagnosis map fairly well to the pathological diagnosis. There's always, DLB is a pretty specific syndrome for having neocortical Lewy bodies, but sometimes patients could have features that meet criteria and don't have Lewy body disease, for example.
Absolutely. We'll get into that in a moment. And then just briefly regarding statistical analysis, they used the generalized estimating equations with a variety of covariates. And I'm going to try to dissect that a little bit more when we get to those results, if that's okay. I'm going to try to share my screen to show you the table 1 that had the demographics for these folks. It's kind of a big table. A couple of interesting things. So just generally, subjects were in their mid-70s when they were recruited for the study. Most of them had mild dementia by CDR scores of less than 2. We observed a expected male predominance in the pure DLB group. That's something we see quite often. And in generally, these folks had about 5.5 years of follow-up, which meant that on average, they had 9.5 assessments that were performed per person, which is a decent amount of assessments, I would say. And there was less than a 1.5-year interval between last assessment and death on average, which again is a pretty short interval, I think, compared to most studies. And you were talking about some of how the clinical phenotypes map on, or clinical diagnoses and phenotypes map onto the neuropathology. So there were 16 cases that were called DLB. 14 of them, so 88% of them, had some degree of Lewy body pathology, either pure DLB or the mixed cases. It's sort of the row assessment across there. But I thought it was kind of interesting. In the pathologically confirmed pure DLB cases in that column on the right, only 7 of the 11, 64% of the cases, were identified as DLB, with the other ones being called Alzheimer's disease when they were alive. And in the mixed group, it was about 50-50. 10 of them had been called clinical Alzheimer's, with 7 of them being called DLB when they were alive.
Probably worth pointing out, that's a great point, David, and that this DLB criteria was from the 1996 criteria. The revisions of the DLB criteria more recently in 2017 include indicative biomarkers to help supplement the core clinical features of DLB that you mentioned. Cognitive fluctuations in particular are hard to elicit by history, and sometimes we can observe them in clinic as short periods of disorganized speech in conversation with a patient, where it's almost like a short circuit mid-conversation to talk about another topic, which could be very distressing to families, or excessive daytime sleepiness. And what's relatively new, and as you know, REM sleep behavior disorder, and having sleep polysomnogram confirmed REM sleep behavior disorder is so strongly indicative of underlying synucleinopathy that's a biomarker support. So even though we can't visualize synuclein in the brain in a living patient yet, there are biomarkers of reduced dopamine transporter, sleep polysomnogram, cardiac scintigraphy that can look for vagal denervation of the heart that can give supportive criteria for DLB. So it's interesting, to those 4 that were classified as AD, perhaps with more modern biomarkers, could they be classified more specifically?
Yeah, that's a good point.
More sensitivity, I should say, to detect those pure DLB cases.
Yeah. Yeah, and then even just based on the sort of some of the clinical metrics anyway, things that are long-standing and well-known. I was thinking about the data on the extrapyramidal syndromes for some of these patients. So it was seen regularly, but it wasn't universal. In even the pure DLB cases, not all of them had extrapyramidal syndromes that were noted here, and same thing in the mixed pathology group. Not all of them had extrapyramidal syndromes here. I guess, to be fair, also, like, the way that they assessed that in this paper, at least reported this statistically, is that this wasn't well, they had probably UPDRS data that was collected here. EPS symptoms, for the sake of the statistics here, were reported as either present or absent on the basis of having, it sounds like, greater than mild degrees of some aspect of an extrapyramidal syndrome, tremor, rigidity, bradykinesia, gaze, at least one of those measures. So it could be fairly sensitive, I would imagine, for codifying somebody as the presence of having a Parkinsonism anyway. Okay, so 5-year survival was better for the pure Alzheimer's group. 68% of them were alive at 5 years, but it was only 27% of the pure DLB cases, and I think that has been borne out in previous literature too. But otherwise, demographic and most of the baseline characteristics of these groups were fairly well matched, I thought, actually. They were coming from a pretty similar baseline anyway, as far as function and cognition anyway.
Yeah, I think you made a good point before about sex associations with pathology and dementia, and the association of male sex with cortical Lewy bodies has been described throughout the literature, and the mechanisms aren't entirely understood, but it raises good importance of examining sex as a biological variable in these types of studies, and that was included in their models, I believe, as one of the predictors. Yeah,
so this is couple of things here, but I thought this was kind of interesting also because, like we had talked about before, one of the unique features of the paper is these functional assessments. So they did some of these correlations of the functional assessments, the ADL scale and the DS, the dependency scale, and it looked like the MMSE numbers correlated well with ADL and DS numbers in the mixed cases, the guys who had AD and DLB pathology, but the MMSE was not correlated, it looked like, in the ADL or DS scores for the pure Alzheimer's disease or the pure DLB cases, actually, which I think is kind of interesting. And I'm not sure that that's really been shown like very systematically before. So there's lots of food for thought. We might talk a little bit more about that later, or do you want to get into it now anyway?
Yeah, I mean, it's interesting that MMSE is a great global cognition screening tool. There's a lot of features on pure DLB that may not be captured by that. Neuropsychiatric symptoms, the fluctuations that we talked about, autonomic instability is a less recognized feature of DLB, where orthostatic hypotension, constipation, these types of things can cause significant functional decline. So in the pure DLB group, that lack of correlation, I would be interested in, more data on, and there's a lot of work to develop new scales that can help capture some of these unique features, neuropsychiatric, autonomic, in addition to motor and cognitive features of Lewy body disease.
Yeah, no, I 100% agree that I was going to imagine that the other features of DLB could could really drive some of the functional impairments that may be independent of what you may be able to capture with an MMSE. But it didn't correlate in the pure Alzheimer's group either. So I'm a little bit curious if there's other aspects of, Alzheimer's disease behaviorally or otherwise that may be affecting, independence or dependency in ways that are not really captured by the global MMSE scale anyway. And those are very clinically relevant measures. Also, it makes me a little worried that if we're tracking MMSEs all the time, that we may be missing other aspects of disease that are maybe more patient centric, honestly.
Yeah, it's a great point. I mean, having stronger links of specific clinical, cognitive, and other features that directly impact function are important relationships to establish to help guide symptomatic therapy development. If we know which symptoms are causing the most disability, that we can target them in addition to disease-modifying therapies that we all really want to help stop or slow these diseases.
Sure. Very good. Let's move to table 2, which has the rates of change for these different measures in these patients anyway. So this table 2 reports 3 models to evaluate these trajectories in these different measures, the full C-mini mental, the ADL scale, and the DS scale. So for all of this, Alzheimer's disease is used as the reference value. Model 1 is adjusted for age, sex, education, in the presence of extrapyramidal syndromes at baseline. Model 2 is adjusted for all of those things, but additionally, the baseline values of whatever the outcome measure is that they are assessing. So for example, model 2, that sort of top row would be adjusted for MMSE, the middle row would be adjusted for ADLs by itself, and then the bottom row being adjusted for baseline dependency scales. And then model 3, all the way on the right, is adjusted for those baseline demographics, but also all baseline outcome measures, so MMSE, DS, and the ADLs all together anyway. I would say that, throughout these models, they see fairly consistent results, even with some of the additions of these extra covariates anyway. And I think that some of the take homes for MMSE, the top row anyway, the DLB group looks like it declines faster across these different models than the Alzheimer's group. That's very significant across all of these anyway. For the ADL subscale, it looks like the mixed group worsens more quickly. And then DLB reaches sort of trend level in some of the models, but doesn't hit significance, it looks like. And then for the dependency scales, DLB and the mixed pathology group seem to worsen faster in some of the models. And in the text, they report mostly the values from model 3. If you're trying to navigate with some of this stuff anyway.
Yeah, it's important to do this type of comprehensive modeling to help adjust for all the different demographics that can affect outcomes, particularly functional and cognitive outcomes that can have so many variables. Later in the, not to jump ahead, but I think they do adjust for ApoE in one sub-analysis and patients at different the end stage disease in the last 5 years. It's important to, I thought the statistics were rigorous to help adjust for those different variables.
Yeah, they didn't report this, but they did say, at least in the text in the paper anyway, that there was no differences observed when they compared the pure DLB to the mixed DLB and AD pathology group. So all of this is presented in terms of reference to the pure Alzheimer's disease trajectories as well. But they did have a nice little paragraph that I think really helped make these models a little bit more, accessible, I think, in sort of, regular real life kind of terms. So it went something along the lines of, so if your Alzheimer's group, if they decline at a 0.61 MMSE per year, that means that in this model, I guess this is model 3 that they're reporting, is a DLB patient, a pure DLB patient with similar characteristics would decline at an additional 1.02 points per year. So that gives them a total of 1.63, 0.61 plus that per year. So that's about 2.7 times the rate. So DLB is worsening 2.7 times a pure Alzheimer's disease in terms of their MMSE score year over year. And if you use that same type of application to the other measures, that would indicate that the DLB, the pure DLB patients are worsening at 1.8 times in terms of their ADL scores and 2.0 times for their dependency scales respectively. So, somewhere in the range of 2 to 2.5 times faster on the pure DLB side than it is for the pure Alzheimer's disease side anyway. So I thought that made some of these models, which are always a little bit difficult to sift through, like you could easily translate that into, more accessible language, which I thought was nice of them to do. And then this is their figure that goes along with this. Also, this shows sort of spaghetti plots for individual data and the linear best fit estimates that are superimposed here. I guess what I was looking at this initially is, if you agree, Dave, also, is that this really does emphasize to me that there's still significant patient-to-patient variability. Anyway, you can still have people who within the pure AD group or within the DLB group, that some of them do get worse a good bit faster, and some of them actually have a little bit more of a benign course. So there's clearly other ways to sort of tease these apart within these individual groups that might help us do some better work in the future as far as their individual prognostication. But yeah, even within the group, there's a substantial amount of variability, it looks like, with some of these measures.
Yeah, and the biological complexity of Alzheimer's, Lewy body disease, and the spectrum in between is vast, and there's known and likely many other genetic risk factors that could influence these trajectories in combination or in addition to the mixed pathology, and as well as other psychosocial factors and things that could affect functional outcomes and things so important. While this is a very rare and important data set, future work can really expand and look more comprehensively at a lot of the different biological contributions to the heterogeneity that we see clinically. There's still a lot that we don't know.
Sure. Let me stop sharing now, just so we can go back to speaking regularly anyway. And then you had mentioned this already, but yes, they did a little supplementary analysis where they restricted the analyses to only those that were within 5 years of death. And the statistical significance was lost for much of the comparisons, but some larger effect sizes were actually observed. Perhaps interestingly, the pure DLB had a faster dependency scale decline than the mixed group. It was just in that scale, not really in the MMSE scores anyway. And that was their analysis. So I thought that the take home was that this is a clinic-based longitudinal study of subjects who had autopsy validation, these pure AD, mixed AD and DLB, and pure DLB cases. Despite their similar baseline characteristics, there were different rates of progression in cognition as measured by MMSE, and also this functional status is measured by the blessed ADL subscore and the dependency scales too. So DLB appears to have a faster decline in cognition and functioning than AD than those with the pure AD cases, and then those with the mixed DLB and AD pathology had a faster decline in some measures of functioning anyway. Some of the effect sizes that were observed here were fairly significant anyway, with a sort of 2 to 2.5 times more rapid worsening anyway.
Yeah, that's always a challenge clinically. Families and patients want to know what to expect, and those functional predictors are very, we're still lacking. It's very hard to, there's so much individual patient variability that, this kind of data is helpful because, like we mentioned in the beginning, if we had the ability to detect alpha-synuclein and tau and A beta, and we could, better prognosticate and then, answer that question. But this is great data to suggest that the presence of synuclein in particular has this effect on prognosis.
Yeah, I think you did mention this also. This really highlights the importance of these autopsy validated studies. Like, you could not have done this type of study without it, of course, and the data would have looked significantly different if you relied on the clinical metrics alone, the clinical diagnoses of these people alone anyway. And this uses extremely rare longitudinally collected data, so this is very useful. Yeah, and since we may be entering an age where in vivo synuclein biomarkers are going to become available in the clinic, perhaps in short order, yeah, we might be able to start characterizing patients earlier in terms of this. at least the presence or absence of synuclein pathology. And we're gonna have to answer the question of what do we start telling patients who maybe look like they have clinical Alzheimer's disease, but hey, their alpha-synuclein assay is positive anyway. So what does that mean in terms of what patients and families could maybe expect? What does that really mean for what we're going to call their underlying disease? Like, are we actually going to move towards biologically determined definitions of what they have? Or are we really going to be sticking with sort of like, Alzheimer's, DLB? Or are we going to move to sort of this bilateral sort of parallel nomenclature of, okay, so you have clinical Alzheimer's disease with tau and A beta underneath, but also some alpha-synuclein co-pathology. Like, we are going to have to think a little bit harder about this perhaps in the future anyway.
Yeah, I think there's a lot of interest in decoupling, Alzheimer's disease as a clinical pathologic diagnosis. Yeah, we think of clinically a patient with episodic memory loss and other domains and older age with plaques and tangles, but as this paper showed and many others, that doesn't always correspond directly to plaques and tangles alone or in combination with other pathologies. So having for example, a multi-domain amnestic syndrome to describe the features, and then with or without biomarker evidence of AD, that's the ATN framework that exists, is a research framework. But as these ability to detect pathology becomes more available and eventually, we hope clinically available, this will help us, refine. It was really analogous to, cancer biology in a way where you have tissue is so available with, different forms of malignancies, but with the brain, we can't get tissue, but the ability to detect these pathologies. I think it's interesting too, like you mentioned, if this was a clinical cohort and it was a clinical trial, there are patients who would be called Alzheimer's disease that could have Lewy body pathology and have this 2 to 3 times more rapid worsening, and perhaps wouldn't benefit from a disease modifying therapy, where other patients in the same clinical bin or clinical cohort would, and we could miss the effect. So bringing biomarkers into the context of trials, which is obviously ongoing now for Alzheimer's and and starting for Lewy body and Parkinson's disease, it's really helpful to start to enrich those cohorts with people with homogeneous biology that would have more likely a more homogeneous natural history that we could then study for an effect to intervene for a clinical benefit.
Yeah, I think it probably depends a little bit on how they would want to apply that biomarker data. I mean, I think that this paper definitely gives you some evidence that people with mixed pathology and DLB anyway have some worsening that's faster than pure AD. And if you wanted to design a trial for people who would perhaps a shorter clinical trial based on those worsening trajectories, that's one thing anyway. But if you're really trying to target a specific molecular pathology and try to exclude those with certain types of co-pathology, that may potentially be another application of some of these things. And thankfully there are some papers coming out around now also that are helping to contextualize the application of these, especially the synuclein biomarkers, in terms of other AD pathology, both primary and secondary anyway. So I want to talk a little bit about some other questions and perhaps limitations about the paper anyway. So, Predictors 2 started recruitment in 1997. And so this is probably has to be to do with some of this, but the measures of AD pathology don't have what we would call sort of like the up-to-date modern NIA-AA criteria. So they use different integrated measures of amyloid stages, specifically the thal phase, in determining degree of AD neuropathology. I mean, I think we see that kind of often. And I'm kind of curious because there wasn't a real systematic assessment of other neuropathologic co-pathologies here. TDP-43 really started getting going in 2006. And, even measures of vascular disease also would be kind of interesting too, to see if there's differences across these groups that could also affect their clinical trajectories too. Maybe that would provide some insight into some of the intragroup variability that you're seeing in some of those spaghetti plots anyway.
Yeah, that's a great point. And the neuropathological criteria for Alzheimer's disease has evolved since 1997 and now systematically characterizes the extent of plaques, tangles, and other co-pathologies like Lewy body, TDP-43, vascular disease, ARTAG is an age-associated glial tauopathy. So, examples of community dwelling autopsy cohorts like the ROSMAP cohort at Rush and others, the combinations of all these different age-related pathologies are really astounding. There's so much heterogeneity. So great point. Like, while very important, we see a strong effect size here for Lewy bodies in the context of AD and DLB spectrum. Future work looking more comprehensively at all these different age-related pathologies will be really interesting.
Yeah, another thing that I was going to bring up too is that I thought they were pretty explicit with some aspects of their statistics anyway. I wager that they were running into some of the same issues that you and I have run into anyway, is that when you're dealing with rare data, especially those who have undergone brain donation anyway, it's sometimes hard to adequately do some of your statistics. Like, for example, there's 62 patients who are involved in this model anyway, and some of these models have a large number of covariates. So I think one could be a little bit concerned about overfitting some of these models. We don't have all the numbers to go along with how some of these covariates were significant or not so. But I mean, that being said, I think they actually did a pretty good job at reporting these statistics, which really gave us some insight into the strength of the model, especially across when they're changing some of the covariates and doing the adjustments. So yeah, I think that also highlights the need for more people to be engaged in brain donation, so we can better power some of our studies actually to be a little bit more confident in some of these things too. Other things that I was going to mention is, the MMSE, it's a fairly coarse measure of global cognition. I think it would be kind of interesting in the future for us to do some more detailed cognitive testing and see if there's domain specific trajectories that might be relevant too. Also, how do you feel about that?
Yeah, I mean, it's a great starting point, the MMSE with the functional data and getting into individual domains with more fine-grained cognitive measures. And you mentioned before the UPDRS was dichotomized, getting into more fine-grained. And, you would know a lot more about this than I do about wearable technology and ability to measure movement and movement disorders more quantitatively would be exciting in future work too. And I know that there's a lot of work in that area that's ongoing. Yeah,
it would be interesting to see sort of more full UPDRS scores also here, since this was sort of a dichotomized extrapyramidal presence or absence of Parkinsonism that they use here anyway. I mean, one kind of core limitation also of these types of autopsy studies that we only get to observe basically a cross-section of neuropathology at the end of life. So, we can't definitively say from the study or any of the types of studies that you and I have been involved in, when exactly some of these pathologies occurred. Did we really start with Alzheimer's disease and the synuclein stuff came in a little bit later, or vice versa? And, beyond which came first, when did this actually happen anyway? Hopefully we'll be able to do a little bit better of this, but that'll in the future. But this will also really help inform a new dimension of how the folks change over time, is how their biology changes too, and when this co-pathology emerges anyway, let alone why. But so a lot of open-ended questions here, but that's that's the nature of where we're at with these types of studies these days, and that's okay. But something to think about in the future anyway.
Great. I think, the other point about diverse populations, this was a largely Caucasian autopsy cohort, and there is a Predictors 3 ongoing now. That's, I believe it's a Northern Manhattan cohort with more diversity. And it's an important aspect of biomedical research, and particularly with neurodegenerative disease and aging, is to have more representative cohorts of diverse backgrounds is really important. There is data that suggests different pathological findings of dementia with different ethnicities, and that's an important part of research. So that's another, I think, important point.
Yeah, no, I 100% agree. I think it's a huge blind spot across most of our knowledge for really all neurodegenerative disease, to be honest. So it's good to see that there's been some more urgent efforts towards recruiting non-white populations, even non-college educated populations, to these types of studies anyway, so we can really better understand sort of the spectrum that we're dealing with in a way that's really just more applicable to the people that we see in clinic anyway. So this will be very useful, inspirational stuff in the future. But I thought this was a really nice paper. I think it taught us a lot anyway, and getting some of these functional assessments in particular is very, very useful, I think, to go along with some of this other data also.
Agreed. Well, that was great discussion and a great paper.
Yeah, no, and yeah, very excellent. And, you know, thanks for taking the time to talk. And as always, great to see you too.